Let's talk about the key functions of the endocrine system. All right, the hormones, again, are implicated in growth and development, of course. Hormones are also implicated in how we like metabolize our everything, right? You metabolize your food, you regulate your nutrients through the endocrine system. All right. Stress adaptation, another key function of the endocrine system, fight or flight. When we're talking about that response, we're talking about the endocrine system, all right, not the central nervous system. Well, of course, the central nervous system is involved because we get the message from the brain that we need to adapt to stress, but a lot of the reactionary substances or hormones that are going to come from that actually come from the endocrine system. All right. And then finally, reproduction. If hormones are important in growth and development, it makes sense that that growth and development begins as early as conception. Okay. So reproduction, is implicated. You'll hear that a pregnant woman is hormonal. So think of that as well. All right. So here we are looking at the structures that are going to be implicated in the endocrine system. And we're starting with the pituitary gland. All right, so thalamus sits somewhere here out of sight. All right, if you can see my arrow, hopefully you can. And then hypo, meaning underneath or below or under, right, is underneath that. So we have that structure. All right, and then connected to the hypothalamus would be the pituitary gland. All right, and the anterior pituitary would be that lobe that appears to be on the front. And when I say the front, I mean the the eyes of the individual are going to be that way, right? Whereas the posterior pituitary faces the occiput. Okay. And then we get from this relationship from the brain giving input to the thalamus, to the hypothalamus, and then to the pituitary, the hormones. All right. The hormones that end up at their target glands. And we'll talk about glands in a second, but hormones and glands go together like peas and carrots, okay? They belong to one another, all right? So the goal of the hormone is to hit the target gland and then the target cell, okay? All right, and the causes and effect. All right, so in so many words, that is an important structure there. The pituitary gland, it has two lobes on it and it comes from the hypothalamus. So hopefully seeing this graphic representation of the pituitary gland will give you a clue as to like its complexity. But know that the gland itself, like both lobes of the not the gland, I'm sorry, pituitary, it is a gland, but it's like the gland of origin. Everything is heading out towards the target glands. Okay. So look at all these different um blood vessel connections that are sending, or not necessarily blood vessels, let's call them hormone vessels, that are sending these important chemicals to their target locations. All right. I just wanted you to have a little sense of what that looks like. Let's see if I can zoom this in a little bit better for you guys. Those as the hormones are released, in the case of growth hormone, it goes out to the tissues, right? We have follicles sorry about that, follicle stimulating hormone and luteinizing hormone heading out to their proper appropriate targets. In this case, let's see how much I can zoom back out. Testes and ovaries. Okay, testosterone is created from the progenitor FSH, all right, and LH, and then becomes testosterone, whereas ovaries receive those and you get estrogen and progesterone. All right, TSH, all right, and it goes to thyroid. All right, and thyroid hormone then does its job. Adrenal cortico T hormone. All right, and it's heading to the cortex of the adrenal gland. Cortico just usually, or cortex usually means the area surrounding, like the brain has a cortex, the adrenal gland also has a cortex. All right, and that's referring to, let's see if we can zoom in on this a little bit better. this little area here would be the cortex of the adrenal gland, okay? That little triangle, lighter triangular area surrounding the inner part of the adrenal gland. So check out those structures. Do you need to know the structures? A little anatomy won't hurt with the hormones, okay? In the endocrine system, because look at all the different targets, okay? All the different targets. All right. This is another depiction that helps us to kind of understand what's happening. Hypothalamus, pineal gland, pituitary gland all live in this center here, right? They target thyroid, or more specifically, pituitary gland with its growth hormone, TSH, yeah, all the ones I just showed you would be these targets, okay? So thyroid, parathyroid, all right? Know that parathyroid is, we'll look at that more as we go, but parathyroid is like the four little dots on the posterior side of the thyroid that are embedded in the thyroid. So we'll talk about what that means when we get to that. Thymus is another endocrine hormone that's really hard to even assess in a patient, but it's there, and it's something you have to see on autopsy or something like that. It's really hard to kind of visualize the thymus. Then we have the adrenal glands, again, very important. And then the islets of Langerhans are glands within the pancreas as well. Okay. All right, so the HPA axis, like way above your pay grade, you probably don't really want to know the full details of HPA, but it's important to know these basics, okay? So the relationship between the central nervous system and the endocrine nervous system or endocrine system is mediated by the HPA axis, or the hypothalamic-pituitary axis, or hypothalamic-pituitary axis. Hypothalamus is the master regulator of all the hormones. Remember that we mentioned that before. And this is how we maintain hormonal balance, is through the hypothalamus. All right. And because the endocrine system regulates mood, stress response, metabolism, all right, disorders within it can produce symptoms that are nearly identical to those of psychiatric illness. And we will get into that, right? So we're over here talking about psychiatric illness. However, if a person has an endocrine issue, it may mimic psychiatric illness. All right. So one of the key principles of nursing would be like having a holistic assessment that includes ruling out like underlying medical causes before you do the psych diagnosis. Have to make sure they're not experiencing metabolic issues that are kind of mimicking psych disorders. For example, if you have a thyroid issue, right, then the thyroid gland produces hormones T3 and T4, and those are central to regulating your metabolism, right, and your mood. So a person who is hyperthyroid or has hyperthyroidism or an overactive thyroid can have anxiety disorders. All right. They can even present like manic or have mania-like states with the anxiety and the restlessness and the insomnia. They can present like that because the thyroid itself which controls metabolism and mood, is overproducing. And coincidentally, or I guess conversely, the hypothyroid condition, where you have an underactive thyroid, can cause problems of depression, okay, including fatigue, apathy, and slowed thinking. If a person is experiencing hypothyroidism, then you're going to want to assess for that, right, before determining that this person has depression. Although if a person has hypothyroidism, it's likely that they may present as a depressed person. All right. The adrenal disorders, those that affect the adrenal gland, those manage stress and fluid balance. So if a person has an adrenal insufficiency, like what you see with Addison's disease, this can lead to fatigue, depression. Whereas if a person has adrenal excess, like you would see in a person with Cushing's syndrome, it's often caused, it often can lead to irritability, mood swings, cognitive decline. All right. So notice how psychiatric illnesses can sometimes appear to be psychiatric, but in fact, they're metabolic. All right. So hopefully you have that idea. Now, I just reiterate that on the HPA axis, you have the anterior pituitary hormones being the star of the show here, okay? Not the posterior pituitary hormones. But knowing the difference between the two can help. All right, ACHT, TSH, GH, prolactin, FSH, LH. All right, I give you the full names for those, but I have them on the next page for you to check them out. All right. And then the posterior pituitary hormones are generally ADH and oxytocin. Honestly, I know there should be a way for you to connect these hormones with the right target glands by merely looking at the names of them all spelled out. All right. But there are also opportunities for you to use flashcards or use other types of study techniques for you to get that down. All right. The anterior pituitary hormones. GH or growth hormone, growth and metabolism. Prolactin is implied in lactation. That's why if a person starts overproducing prolactin because of a certain medication they're taking, yes, they will begin to lactate. Absolutely. All right, ACTH, adrenal cortico, I just can't remember the word. Sorry about that. Cortisol release. Okay. The C in ACTH is cortico. All right. And it's referring to cortisol, which comes from the cortex of the adrenal gland. Okay. So in the cortex of the adrenal gland is where we're going to be creating and releasing ACTH. And that's again implied in fluid balance. TSH or thyroid stimulation has to do with the T3 and T4 that I mentioned before. And if it's underproducing, you have a hypothyroid individual. If the TSH is overproduced, then you're going to get a person who is hyperthyroid. And then the FSH, follicle stimulating hormone, and LH, luteinizing hormone, are both associated with reproduction. All right. So repetition there for a reason. All right. Your posterior pituitary hormones, ADH. Those are, I have to make a correction. Here I mentioned ACTH. That is not your fluid. No, which one was I mentioning that had fluid? Disconnect what I said earlier about fluid balance because I really want you to focus on the posterior pituitary hormones as being about fluid balance. Really, seriously. So make how can we do that? I don't know, but associate posterior with the fluid balance issues. I might have unintentionally mentioned fluid when I mentioned ACTH before. I may not have. I can't really remember, but I just want to make sure that the anterior pituitary hormones are not necessarily connected with fluid regulation. However, the posterior pituitary hormones are, okay? And let's just start like working this out. ADH, also known as vasopressin. Vasopressin is the name of the actual compound in the body, but it's also the name of the drug that we use to replace this ADH. Okay, so ADH and disorders that are connected to ADH. Vasopressin. I don't mind if you remember the name vasopressin. It does show up on a lot of exams, but ADH and vasopressin are the same and they are about water balance. All right. Now remember, prolactin was over there on the anterior pituitary hormone, but oxytocin is over here on the posterior. Oxytocin is very helpful in bonding with other individuals when you're in love or when you have a new baby. You are firing off lots of oxytocin. All right. It also helps like in the process of labor, the different stages of labor. When oxytocin goes off, it's usually indicating that the baby has been delivered, and now it is time to begin closing things and shutting down the uterus again. All right. So not shutting down, but closing it back up or retracting back to the normal pre-pregnancy musculature. All right. So with that said, keep those two separate. Okay, but remember, these two disorders here are about ADH. Diabetes insipidus and SIADH, you will see these a lot. And again, these are rare disorders, but if something goes wrong, they want to know that you're the new nurse who's going to be safe and that you're going to at least try to question what's happening with your patient here. All right, so usually you don't get DI or diabetes insipidus or SIDH unless there's been some kind of like trauma to the pituitary gland. And they will cause, because the pituitary gland, because it's so important, it's deeply embedded in the brain. So it's not often that, just a little jostling is going to make a difference, in all of these important autonomic systems here. But yeah, you get people who have cranial surgeries, you get people who have trauma due to, say, for example, a car accident, that kind of physical trauma that would actually penetrate or pierce or otherwise introduce trauma into that area where the pituitary gland is. Okay. Nature tends to be protective, but trauma happens. That said, diabetes insipidus is when you have low ADH. And when a person has diabetes insipidus, they will have sodium and fluid imbalance issues. All right. A person who has SIADH has too much ADH. Those with DI have too little. All right. So we're going to talk more about these sodium issues as we go. All right, your thyroid hormone functions, we've mentioned them already a little bit, but T3 and T4 are your key thyroid hormones. All right, they regulate metabolism, they regulate our energy, our mood, are all connected to thyroid. All right, hyperthyroidism, we mentioned before, will give you anxiety, irritability, insomnia, almost like manic type episodes, whereas hypothyroidism is going to you're going to go down. You're going to be a little depressed. You're going to have fatigue. You're going to be slow. You're going to be cold. All right. You're usually cold with hypothyroidism, hot with hyperthyroidism. Hyperthyroid people are usually thin because they're just moving, very irritable, anxious, and they're often underweight, whereas hypothyroid people might be a little overweight, right? They're fatigued, depressed, slowed down. All right. Thyroid disorders. So we mentioned it already, right? Hyperthyroid anxiety, hypothyroid depression. So we really want to monitor the TSH in patients because, especially if they present complaining about psychiatric issues, because maybe it's their T3 and T4 levels that we can modulate and they feel like themselves again. All right, usually with these endocrine issues, replace what's underproduced and you're good. But the problem is that hormones are difficult, unstable medications. They're typically challenging to give. And then you have to, as the nurse, give them in a set range because, again, as we can see, too little of something causes one problem, too much of something can cause another problem. All right, so we usually have tight ranges, and with the endocrine system, we're just replacing what there's too little of and what there's too much of. We're trying to maybe block receptors and stop the production. Okay. All right. So calcium and bone regulation will involve PTH. All right. Calcitonin and vitamin D. All right. So increased calcium. You're going to get with a person who's experiencing excess calcium. All right. They're going to reabsorb calcium into the bone, all right, to essentially strengthen it and make it and kind of like recycle it, right? Or PTH can be reabsorbed by the kidney. Calcitonin, all right, that's implied when the patient has low calcium, all right, and then there's a thyroid hormone that regulates calcium. And then vitamin D, right? Usually the presence of vitamin D will increase calcium absorption from the gut. And that is why we take calcium and vitamin D together, because just the presence of vitamin D along with the calcium will improve calcium absorption, which is what we want. Okay? We want to get calcium so we can have regulated calcium levels. All right? Why? Because calcium imbalance can cause irritability, confusion, and fatigue. Those are three kind of nondescript like side effects: irritability, confusion, and fatigue. A lot of things cause irritability, confusion, and fatigue. All right, so you have to be careful when you are looking at a patient who has calcium issues or calcium imbalance, because again, we have a tight range to get them into where they have enough for bone reabsorption and bone strength, but not so much that they are having that excess calcium create problems that they didn't have as well. All right. So now I have a graphic here, right? And this graphic, let's see if I can get a little closer here. Shows the connections that will, or the mechanisms or mechanisms of action that will raise calcium versus those that will lower calcium levels. All right. So a lot of times having too little calcium in the blood, so low serum calcium or hypocalcemia, will trigger the posterior lobe of the hypothalamus. No, we're not. We're no longer in the hypothalamus. We are now in the metabolic system. All right. I've been doing this too long. Will cause increased PTH secretion, right? Which will then kick in lower or less calcium being excreted by the kidneys. So kidneys hold on to calcium as soon as there's more PTH hormone secreted from the glands, okay? And then a patient who has a patient in this situation who's reabsorbing calcium from their kidneys, or not excreting more calcium than what's needed, will experience increased absorption of calcium also in the intestines, especially via the activation of vitamin D. All right, which will then, if there's enough calcium in the body, they will release some calcium from the blood. All right. So the calcium, when it's low in the blood, from the bone. So if there's too low calcium in the blood, it sends a message to the brain to give us more PTH. We get the PTH, and then that stops kidney from releasing too much calcium or releasing calcium. All right, which then it causes it to increase in our body, and then that actually tells a little note to the bones, give us a little bit of calcium as well from the bones. Bones reabsorb calcium, so they can also release calcium. And then releasing calcium from the bone causes an increase in blood calcium. Okay. So with that said, these mechanisms, or these are concept maps really, that show you relationships and the order of things. And this is where I plug you creating your own concept maps. Again, with your books put away and without a whole lot of interference from your notes, try to see if you can recreate this on your own, right? The concepts, the ideas that are in these concept maps. All right. So calcium levels. I don't know that I'll be training you on the pathophysiology of calcium level changes. I'm really more wanting you to know that there's a connection between the pituitary, not the pituitary, sorry, between the thyroid and calcium. All right. Adrenal cortex. This is where you're going to see matters that um, matters that are connected to too much cortisol and too little cortisol. All right. So let's first talk about cortisol. Cortisol, uh, that little part of the adrenal cortex that I showed you earlier, that kind of the lighter part that outlines. Let's just go back really quickly. That little, let's see, I'm able to move it there too. Here, that little cortex That's what we're talking about, right? This is where cortisol is being released, all right? It's actually made on the inner part or the inner medulla of the adrenal gland, but it's the cortex or the surrounding part of the gland that actually releases the drug into the body. And once the cortisol goes off into the body, that's where you get those metabolic effects like increasing glucose levels. Why? Because in fight or flight, we need more glucose so that we can run away from the bear, right? So if we're going to run away from the bear that suddenly shows up, we need blood sugar go into all our muscles so that we can do that. So with that said, though, if there's no bear, you're just building up all this blood sugar and you're not, doing anything to bring about the balance needed. All right, so let's get back to where we were because we are making our way through there. Let's talk about the adrenal disorders. All right, so cortisol, stress response, and glucose regulation, right? So when a person has too little adrenal function or too, maybe there's something wrong. Usually there's something wrong with the gland and that causes under secretion or over secretion, right? So we can't always predict which way it's going to go. The endocrine system is so complex, and these hormones are in such a tight little and they're such in a tight little range that it's easy to experience excess. I'm sorry, I need to respond to this call that's coming in. Um, can I call you later? All right, sorry about that, guys. Okay, so adrenal excess is experienced as Cushing's syndrome. All right, I do have a slide about those two, so let's talk about them in a second. But no, also, I just don't want you to forget that aldosterone, where we get our sodium water balance, aldosterone is another adrenal cortex hormone. And androgens, those are all the sex hormones. This is where we're going to get estrogen, progesterone, testosterone created and released. All right, adrenal androgens. Ag is talking about maturation. Okay, maturation and yeah, pretty much maturation. All right, so what does it look like when we have too little adrenal hormones? We're going to see disease. Addison's disease. All right, so it can look like depression. All right, it can look like fatigue. Um, Addison's disease. Now, those people have too little cortisol. They are so, they have so little cortisol that if they do have a stress introduced, they faint. There's nothing to help them respond to the stress, the fight or flight. So they see the bear coming to the acutely, they're going to just pass out or under respond. They are not going to do what it takes to save their life, but they usually just go into shock. And instead of having hyperglycemia, they actually experience hypoglycemia, which is essentially a form of shock. All right. So that said, with adrenal insufficiency or Addison's disease, you're going to have to add more cortisol. You have to give them cortisol treatments to help them just regulate and have a normal response in the terms of a shock or a surprise or stress, but also to help with energy and to remove some of that depression. Okay. Whereas excess or too much cortex or cortisol would lead to Cushing's. Cushing's. I like to think too much is cushy, like a pillow that's overstuffed. It's cushy, like cushions. Okay, so that helps me sometimes. Too much cushy. Whereas Addison's disease, I think what's good about Addison's is that if you have Addison's, which is too little, you have to add a corticosteroid or add cortisol. Okay, it's usually in the form of a corticosteroid. All right, that said, back to Cushing's too much. What happens is either they have a tumor on the adrenal gland or they have been using corticosteroids too long. This is how you get excess adrenal activity. All right, so either there's a tumor or some kind of tumor, I say an external, factor acting on the adrenal gland, or people overuse corticosteroids, either as a treatment for cancer, they use a lot of steroids, or maybe a person who actually illegally ingests steroids, um, like synthetic steroids for the bulking up effect that they would like. All right. So what are those symptoms going to look like? That said, a person might get the moon face. This is where they have like this rounded face, like maybe before they have a more like long face, but with these Cushing syndrome, they will begin to develop like a pie or moon face shape. All right, the buffalo hump. This is where they will develop a fatty deposit right there on the back of their neck area. Like right here. I guess buffalo have that hump right there in that area, but it's unique. It's just like a random place to store the extra blood sugar that's in the body. It's like a different kind of obesity. All right, but there also is the central obesity or the abdominal obesity, or the kind of fat deposits around the abdominal area. And then they get fragile skin. Fragile skin. So these are some of the symptoms, but there's a host of symptoms that come along with Cushing syndrome. All right, but in terms of their psychiatric needs, they may look like people who are depressed. All right, I know that Addison's people can look a little fatigued, but fatigue and depression aren't the same thing. They are not quite the same thing. Depression has more to do with a kind of an extended state of anhedonia and some of the other symptoms that we have there. Um, yeah, so depression, I don't want you to confuse it with fatigue, because then you would confuse the two disorders. And I want you to find terms that distinguish one from another. Okay, that's going to help you the most on an exam. All right, they might also have cognitive decline. And in a person who's perfectly intelligent and alert and oriented times four, you will notice after extended steroid use that a person may not be able to think right. Their executive functions going down. They're just, and this could be connected to the irritability. They're just not able to concentrate as good. All right, so the stress response, right? We know that cortisol is to aid in the um, stress response. But when a person, and we know what happens in the short term, but when a person is experiencing chronic stress or stress that's sustained over a period of time, like they literally are firing off their fight or flight. So we're not just talking about the chronic stress of going to nursing school. Sorry. We're talking about, I know you're probably thinking, wait, am I at risk for having Cushing syndrome? Um, Absolutely not if you don't have that other stuff going on. But that said, chronic stress at a high level can have or come with sustained cortisol release, right? How much can the body take, right? You're supposed to fight or flight and then restore yourself back to, that's what the parasympathetic nervous system is for, to help you restore back to rest and digest is what they call that system. So you can, the heart rate comes down, the functions of digesting food begin to restore. So rest and digest is parasympathetic nervous system response when it's appropriate. But if you're having chronic stress and you are basically in fight or flight mode the entire time, yeah, a, that's going to have its effect on one's mood, and will cause that instability of mood, right? It will disturb the sleep, create anxiety, create depression, because the hormones are out of whack. The body doesn't quite know how to respond. And yeah, because the stress or the cortisol never stops firing. All right. So those people, do require a certain amount of attention, because that long-term firing can lead to depression or anxiety. All right, so thyroid dysfunctions, what do they look like? So, in terms of mood, because if we can make some connections between mood and personality, well, not personality, but mood. Personality is a little more fixed, mood is more transient. But that said, when there's a thyroid dysfunction, whether it's hypo or hyper, you're going to experience some differences in mood. Okay, so nurses should always consider having those thyroid labs pulled. And how do we do that? We communicate to the team that, we have our concerns and we would like to see what those levels look like so that we can educate the patient accordingly. Okay. All right. And when they say consider labs, that means check for them, right? It doesn't mean always order them. They may already be ordered because of the patient's history. All right, so do you get the fact that, or you pick up what I'm putting down about the idea around the connection between the endocrine system and mental health? All right, the thyroid, adrenal, pituitary are all connected and they all can mimic psych illness. So we have to rule out medical issues before going into a psych diagnosis because those psych meds are so um, symptomatic. Like they provide so many new side effects and adverse effects that we don't love. So we'd like to essentially holistically treat the person for what they're struggling with and not mistreat the person and give them a medication that doesn't really get to the bottom of the problem. Okay? Because we don't want to have to remove the thyroid or have to, well, maybe we do need to remove the thyroid if it's hyperactive. All right. So this isn't a class to talk about that as much, but know that with these hormone issues, we're usually removing or replacing something that was missing.